Hi everyone. We are so elated to meet you in the program of Take at a Bench. Hi sir.
Hi.
So shall we move on to the session?
Yeah.
Okay sir. 28 years old male patient presented with high grade fever with the chills and rigors and leukopenia sir. He was turned out to be enteric fever and he was successfully treated with azithromycin. So how did you choose azithromycin sir?
Actually, azithromycin is a wonderful antibiotic, I could say. Why we chose azithromycin? Azithromycin has excellent tissue penetration. See what they say when you administer azithromycin, almost its intracellular concentration is much higher as compared to plasma level. If you look at the pathophysiology of enteric fever, most of the time the Salmonella typhi organisms reside in macrophages. So azithromycin is extensively distributed inside the macrophage, because of which it kills bacteria effectively. So the relapse with azithromycin is less common as compared to quinolones. That's why we prefer azithromycin as compared to quinolones or any other drugs, especially in the case of multi-drug resistant enteric fever. The most important thing is it has good tissue penetration. So when you administer azithromycin, the concentration of azithromycin inside the cells is much higher as compared to plasma level. That's the most important.
Okay, sir. Yeah. So, what is atypical organism, sir? Then why azithromycin is preferred in infection with the atypical organisms?
So, actually, atypical organism, why it is called atypical organism? Generally, any bacteria, it has its own cell wall. When you say atypical organisms, these organisms lack cell wall. That's very important. So, what are the atypical organisms? You can remember a simple one, a mnemonic, MLC. It's a very common term in our circles. MLC means medico-legal certificate. Am I right? MLC. Here, you can remember M for Mycoplasma, L for Legionella, and C for Chlamydia. So, these atypical organisms lack cell wall. That's why it is being called atypical. Point number one. And second one, unlike other bacteria, it can't be easily visualized by gram stain and it can't be cultured by any other method or any other means very simply. That's why it is called atypical organisms. Since these organisms, MLC, Mycoplasma, Legionella, Chlamydia, don't have cell walls, the penicillin and cephalosporins, these antibiotics generally attack bacteria by inhibiting the cell wall synthesis. Since these atypical organisms don't have cell wall, penicillin and cephalosporins are not useful in treating against these infection. On the other hand, azithromycin is considered as a bacteriostatic. You mean bacteriostatic is nothing but that prevents multiplication of bacteria. Bactericidal means it kills bacteria. So azithromycin is considered as bacteriostatic. So usually it attacks bacteria by inhibiting the protein synthesis in the bacteria. So azithromycin doesn't require any cell wall to destroy the bacteria. So that is the hidden secret. But penicillin cephalosporin requires bacterial cell wall to attack bacteria. So these atypical organisms are not attacked by these penicillin and cephalosporin. On the other hand, azithromycin inhibits protein synthesis in these atypical organisms. That's why it is very well effective against atypical organisms. So when you suspect atypical organisms, for example, if you take community acute pneumonia commonly caused by Streptococcus pneumonia, you are aware that sometimes these atypical organisms can produce community acute pneumonia. So they present with profound muscle pain and more constitutional symptom, and they will have dry cough. When you take chest X-ray, instead of getting homogeneous opacity, you will have heterogeneous opacity. Here and there patches on both the lungs will be seen, and they will have extrapulmonary manifestation. These are the future of atypical organisms induced pneumonia. But any community acute pneumonia, these atypical organisms also participate in induction of community acquired pneumonia. The moreover, it is very difficult to prove that atypical pneumonia. Okay, suppose if it is community acquired pneumonia secondary to streptococcus pneumonia, Gram stain may throw some light on this. Sputum culture can detect streptococcus pneumonia, and even the biofare. There are so many investigation, but if you take atypical pneumonia, it is very difficult to prove that you are dealing with atypical pneumonia. So generally, any community acquired pneumonia, apart from introduction of cephalosporin or penicillin, we used to put azithromycin as a part and parcel of treatment for community acquired pneumonia, because it is very difficult to detect these organisms during evaluation of community acquired pneumonia. That's why azithromycin is preferred in atypical organisms. So atypical organisms lack cell wall. So azithromycin is preferred because it can attack atypical organism by inhibiting the protein synthesis. That's the reason we prefer azithromycin in atypical organisms.
Okay, sir. So what is the antibacterial spectrum of azithromycin, sir?
Yeah, azithromycin is considered one of the broad antibacterial spectrum antibiotic. But what you have to remember that it can act against gram positive, it can against gram negative, and it can act against atypical organism. I don't think that azithromycin is effective against anaerobic. So when it comes to gram positive, so it can act against streptococcus pyogenes. So when you segregate the classification of streptococci, they based upon the hemolysis, they will say alpha hemolysis, beta hemolysis, and gamma hemolysis. Among this beta hemolysis, you have streptococcus pyogenes and streptococcus agalacti. So this streptococcus pyogenes is responsible for pharyngitis and followed by rheumatic fever. So any patient who presents with pharyngitis, when you assume that it is induced by streptococcus pyogenes, I think that is one of the important drugs, okay, for treating against pharyngitis induced by streptococcus pyogenes. So it can act against streptococcus pyogenes. It can act against streptococcus pneumonia. I mean, it is under alpha hemolytic streptococci, and it can't act against a MRSA, of course, to be honest. So this is a most important gram. So that's why we used to give azithromycin for all upper respiratory infection, okay, whether it is pharyngitis or tonsillitis or even acute otitis media and sinusitis, you can give azithromycin because it can act against streptococcus subgroups. That's one important point. And when it comes to gram negative, okay, please remember that it is not capable against something called Pseudomonas and Klebsiella pneumonia and so on. But the two important organisms, okay, that are very much submissive to azithromycin is nothing but H. influenza and Moraxella catarrhalis. Okay, what is the importance of H. influenza and Moraxella catarrhalis? These organisms are responsible for acute exacerbation in COPD. So any patient who presents with acute exacerbation in COPD, we use azithromycin liberally only because of this, because both H. influenza and Moraxella catarrhalis can induce acute exacerbation in COPD. So in that way, it is very active against gram negative. One more gram negative bacteria, as I discussed earlier, Salmonella typhi. So we are using azithromycin extensively against Salmonella typhi. When somebody presents with high grade fever, with chills and rigor, and with leukopenia, generally any patient who presents with leukopenia second and third day, definitely you have to suspect viral fever. We are tempted to go for dengue immediately. And when you have leukopenia and thrombocytopenia, I think that your assumption is much strengthened. But what you have to remember that the 5th or 6th or 7th day, somebody presents with leukopenia and eosinopenia, very importantly. Dr. Suresh Kumar, infectious disease consultant, he used to tell us generally, any enteric fever, when you suspect enteric fever, look at eosinophil count, it would be as low as 0%. So in that case, leukopenia 6th and 7th day with chills and rigor fever, draw for blood culture, draw blood for culture, then you institute azithromycin. Here what generally we do, azithromycin we give a higher dose. So instead of we give 500 milligram daily once, when you give azithromycin, when you escalate azithromycin 1 gram per day, when you suspect enteric fever, they say that it action transfer from bacteriostatic to bactericidal. When you give 500 milligram, it act like a bacteriostatic drug. That means it can prevent multiplication of the bacteria. It is not capable of killing the bacteria. But when you escalate the dose to 1 gram, so it can kill the bacteria, so-called bactericidal drug. So we used to give 1 gram azithromycin for 7 days in multi-drug resistant enteric fever. So in that way, under the category of gram-negative organism, it is very useful. Then Neisseria gonorrhea, in many sexual transmitted disorder STDs, azithromycin is extensively used. So these are the gram-negative organisms that are easily amenable to treatment with azithromycin. And of course, as we described earlier, atypical organisms also very, very important. But another important is what are the subgroup of population. So if you take renal impairment, I think that you can give azithromycin liberally. Hepatic impairment, I think that you should exercise some caution. They say that there are some rare incidences of elevation of transaminase, and rarely it can produce cholestatic jaundice as well. Otherwise, you can give liberally in all kind of renal impairment and even liver impairment patient with a little bit caution. And with respect to pregnancy, second trimester, third trimester, you can liberally give. It is considered as a category of B drugs. So B category means there is no risk in human and as well as animal studies. But only one thing is, when it comes to first trimester, probably when you don't find any alternative, then probably you can go for azithromycin. But still, cephalosporin as the first line drug during the time of first trimester, that you have to remember. Then breastfeeding mothers you can give. There is no contraindication. The only one area where azithromycin is considered, how very rarely it can poses big threat to our life is QT prolongation. There are few reports which reveal that azithromycin can prolong your QT duration, especially in ECG. When it prolongs QT, what happened? The patient is vulnerable for developing polymorphic ventricular tachycardia. So literature says that when you combine azithromycin with antipsychotic drug, especially quetiapine or amitriptyline and haloperidol, and you should be very careful. So those who have underlying cardiac disorder, I think that you should be very mindful about introduction of azithromycin. Otherwise, I could say azithromycin is a wonderful drug. It has broad spectrum antibiotic. I could say it is very good active against gram-positive organisms other than MRSA, and it can act against gram-negative, including Salmonella typhi, bearing the Enterobacteriaceae family, I mean mainly Pseudomonas and E. coli. Then it has good activity against atypical organism. So with this, I would like to reiterate that use azithromycin judiciously. Make sure that you never indulge in producing azithromycin resistance organism.
Thank you, sir. Thank you for your eye-opening session, especially that MLC mnemonics. Okay.
Yeah.
Thank you, sir. We will meet in the next session with another interesting case. Thank you.
Thank you.